The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference. To reinforce exactly what Ronaldo has said, in that QSOFA is not a screening tool for sepsis, but if you assume someone has an infection, it actually puts you in a worse prognostic group. Just a conflict of interest, and was an advisor for Eastern Health and no longer do that. I advise pro bono for the Commission. We've had an unrestricted education grant from Edwards, which I'm going to talk very briefly about, but I received no other royalties or payments or assistance for travel in relation to any of the work I do, and specifically the work in this talk. So what we're going to cover is a bit about the epidemiology of sepsis, talk about how much we know about non-ward septic patients versus septic ward patients, how delayed intervention worsens outcome, and then, as Ronaldo alluded to, some studies of sepsis within the Met, a bit about the stuff we're doing in measuring cardiac outputs non-invasively, and then my thoughts about how the Met, or a Met-like approach, can improve sepsis outcomes. So we know a massive amount about how patients present to the ED with sepsis. That was the basis of the ARISE study and all the epidemiological data that occurred before. We know specifically in Australia and New Zealand how many patients presented with sepsis went to ICU between 1997 and 2005. There's a lot of data from the US, and importantly, in all the studies that have looked at it, up to a half of the patients who present to ED with sepsis go to the ward. They don't go to the intensive care unit. And particularly in the first 48 hours of their admission, they're prone to instability because their illness is yet to be sorted and stabilised. There is a lot less information on ward patients who have sepsis. We did a point prevalence study of SIRS criteria on the Austin. This is when SIRS was still in vogue, and we found that about 7% of patients had criteria for sepsis. This is a small study in one hospital. We know that delayed intervention is associated with worse outcomes. So, for example, delayed administration of appropriate antibiotics. And people talk about antibiotics, but it's actually antibiotics which are appropriate for the infection the patient has. And increasingly, we realise that protracted hypotension probably is associated with worse outcome. And I think that's driving studies to look at the need for early commencement of vasopressor therapies in a number of areas of the world, particularly noradrenaline versus more fluid. How does this all fit in the context of rapid response teams? Well, we have specialised teams that review deteriorating patients on the ward, and they're activated when patients fill predefined criteria. And at the Austin, these are the criteria that are fulfilled, and they're based very much on physiology, particularly respiratory rate, heart rate and blood pressure. Also, there's urine output and altered conscious state. And it'll become very apparent why sepsis might be a very common trigger for rapid response team calls as we go through. So how common is sepsis during MET calls? I went into this naively and without any preconceptions. This is one of the first studies I did as part of my MD to look at what is the clinical cause of deterioration. And we looked at 400 consecutive MET calls, and all we did was looked at what the registrars had written in the free text comments. And some patients had more than one criteria, but we found that sepsis was associated with about a quarter of all the criteria. And so this is directly out of the table. And again, I had no preconceptions about what the role of sepsis was in rapid response teams. And it's the top three in every one of the triggers. And in some physiological triggers, it triggers it multiple times. Sepsis was often just written as a non-discriminate thing, but in some systems the appropriate organ-specific infection was listed. So then we went on, that triggered me to look at, well, how common are SIRS criteria and sepsis in the context of MET? This was a retrospective study done by an infectious disease registrar and a senior ICU registrar. And we looked at 358 MET calls over 3 months in 2011. And we simply asked, did they have SIRS criteria in the 24 hours before and 12 hours after? And if they had SIRS criteria, did they have evidence of infection? And we had predefined criteria for that. And then subsequently, did the patient have antibiotics? Were they on antibiotics, and were antibiotics changed afterwards? And again, you can see these are our criteria for triggering a rapid response team or a MET call, and they well exceed the SIRS criteria in the appropriate domain. So it's not surprising to find that 3/4 of all the patients who had a Met call in that period actually fulfilled SIRS criteria in the 24 hours before and the 12 hours after. However, a significant proportion of them, 42% or a substantial proportion, had other criteria for an infection, other criteria for SIRS criteria present. But half of them had evidence of an infection, and in roughly half and half it was hospital and community acquired. So then over all of the calls, approximately 44% had criteria for sepsis, and in a quarter there was no other explanation for the SIRS criteria other than infection. And not surprisingly, this is what we see in all of our literature. The most common source was chest, abdominal, urinary tract, and then bloodstream related. And as I said, about half and half were hospital and community acquired. Interestingly, about 80% of the patients who were thought to have an infection were already on therapeutic antibiotics. This wasn't prophylactic, but of interest to me, about half of them had their antibiotics changed or escalated afterwards. And if you had an infective Met call, it actually was associated with about a 6-day prolongation of your hospital length of stay, and that was highly statistically significant. That wasn't corrected for multiple other variables, so it may have just been an association or a confounder. So then we went on and did a much more robust study. We did a prospective study, now looking at QSOFA signs. You'll see we had about 300 Met calls in 3 months previously. Now we've got 258 Met calls almost in 1 month. So this was done about 3 or 4 years later. And we asked the registrar and the nurse at the time 4 questions. What were the worst vital signs in the 6 hours before and after the Met call? Did they think the patient had an infection? And if so, what was the source? Was the patient on treatment antibiotics before, and did you commence them or change them afterwards? And we defined, as you've heard Ronaldo just talk to, QSOFA criteria were an altered GCS, and we just asked them, was it normal or abnormal? Were they tachypneic, and did they have systemic hypotension? And then afterwards, we assessed, we didn't get the registrars to do all this because we thought it was too burdensome. Did they measure a lactate in cultures? Did the patient need intensive care, and what was the intensity, and what were the hospital outcomes? And I won't go into this in a lot of detail because it's currently in press in resuscitation, but 40% of the patients had QSOFA criteria during their Met call, and they had markedly worse vital signs. They were more likely to be admitted to ICU, to have a repeat Met call, and to die in hospital. So this is outside of sepsis. This is all comers with a Met call. If you were QSOFA positive, your outcomes were terrible. Okay, so this is not just a screening tool for sepsis, but it's a screening call for our Met, and it's 3 vital signs to check on. Approximately 50% of all of the patients who had a Met call had presumed infection, just based on what the registrar thought. Now, there may have been other concurrent causes of deterioration, but if you had QSOFA and sepsis, as opposed to just sepsis alone, you were twice as likely to be admitted to the ICU, and you were more likely to die in hospital. But I think because now we're slicing it a little bit thinner, it didn't reach statistical significance. So that may or may not be true. So the next thing we've done is try to estimate the cardiac output non-invasively in Met calls, and this is a 50-patient pilot study where we got a research member of our team to go to hemodynamically unstable Met calls, so they either had hypotension or tachycardia, and we used the ClearSight device, which is in the Edwards stall that you can go and chat to them now. They've got much more expertise than me. It's a non-invasive technique, and we were able to get a signal out of 47 out of the 50 of these patients. So these are quite unstable patients, and we could get a reliable signal. Very briefly, it's a modified, almost like a saturation probe, which inflates and deflates very quickly and estimates the blood pressure and derives a arterial waveform. So it deflates and inflates 1,000 times a second. And it's measured roughly at the level of the heart, and it gives you, similar to PICO and Vigileo, an estimation of the stroke volume and stroke volume variation. So it's a pulse contour estimation method, but obviously it doesn't involve invasive lines and the setup time is a bit more rapid. What we found was that the cardiac output estimated during the rapid response team call was, on average, extremely high. So the average cardiac index, or the median, sorry, I should say, was about 3.5 litres per metre squared per minute. And only a quarter had a cardiac index less than 2.7. And then we asked the level of agreement with the registrar, and we found that the registrars had a very poor level of agreement. So this may add further information, just as Charlie alluded to echo in his previous talk about assessment of the circulation in hemodynamic unstable MET calls. So what other information is there in relation to the MET and sepsis? Well, in Sweden, in the Karolinska Institute, they look at all the unplanned ICU admissions between 2007 and 2009, and they simply asked, was the patient admitted in the context of a MET call? Yes, no. And they found that patients admitted in the context of a MET call were older by some 7 years. They had more comorbidities and a higher Apache, but they were about 2 to 3 times more likely to have severe sepsis. That definition was still relevant at that time when they published this paper. There's a group from America who looked at incorporating an antibiotic algorithm for septic MET calls, and they found it improved the appropriateness of antibiotics from 54 to 86%. And again, this is a system change embedded in an existing structure. So how then can medical emergency teams theoretically improve the outcomes of sepsis? Well, the MET itself is involved in identifying deteriorating patients via the afferent limb. It provincially provides expertise, and it can triage and assess ICU admission. So the MET might improve ward-based sepsis by better detection, earlier detection, more senior response, and a more rapid admission to ICU and a commencement of vasopressors. These are all theoretical and yet to be tested. This is an article that Ronaldo and I wrote with a senior registrar from St Vincent's Hospital, going through how we think the steps of improving sepsis should be done towards the future for ward patients. And I won't go into detail for the interest of time, but basically we should reliably measure vital signs and laboratory tests, and they should be rapidly escalated to the treating staff. We need new biomarkers, and Ronaldo alluded to the fact that there are currently no biomarkers which are sensitive and specific for the detection of sepsis. Every one that's been developed is found to be not specific and not sensitive. And once we detect abnormal vital signs, they should be escalated quickly, and we should make sure that there's structured handover. Staff should identify organ dysfunction promptly, but most importantly, and Ronaldo alluded to this, we have systems for the recognition of STEMIs and audit of STEMIs. There are no hospital-wide governance mechanisms to audit the detection and appropriateness of treatment for sepsis, and I think that needs to change. And then if patients fail to improve, they need to be referred to the intensive care for escalation of care. So this is it summarised. Rapid detection of the clinical features, education in the recognition and response of organ dysfunction. If a patient is unstable, their care should be escalated, and when the patient is transferred, there should be a structured handover. And as new evidence is acquired, it should be applied. And the domains that are obviously target should be antibiotics, fluid administration, vasopressors, and potentially immune modulation. And there should be timely transfer to ICU where appropriate. This is summarised in this diagram. We should have overarching governance, procedures, policies, audit and quality improvement. And within that, there should be education and training. And then these should focus on detection, recognition, the initial response, which should be prompt and definitive. And there should be then subsequent escalation of care. So in summary, the MET criteria provide objective evidence for clinical deterioration. And as Ronaldo's alluded to, if you have SIRS and QSOFA criteria, particularly QSOFA criteria, it puts you into a greater risk group. The responders are often from ICU, and so we have a potential to impact on that. Sepsis is very sexy, outside of the ICU, in the ED and even in the ICU, but for some reason the ward-based clinical deterioration due to sepsis has slipped through our net at the moment. Infection appears to be a very common cause for Met calls, and even if it was only 15%, 2 or 3 years ago there were 100,000 Met calls in Australia and New Zealand each year. That, I'm sure, is more now. So we're talking about 15 to 20,000 patients a year having sepsis as an important cause of deterioration on the wards. If you have QSOFA criteria, you do worse. And a MET or a MET-like structure, and I know some hospitals in the States are developing sepsis teams, may provide an opportunity to improve outcomes for sepsis on the ward, and there is a need to have a whole hospital response, as Ronaldo's alluded to, for the governance, audit and quality improvement of patients with sepsis. Thank you very much.